I'd like to thank everyone for joining us today. My name is Stephen Aquario. I'm the Executive Director of the New York State Association of Counties. And today we're very pleased to present to you today's webinar on slowing the spread of COVID-19. This is part one of a three-part series that we're going to be hosting this week. Today we're going to be examining wastewater to detect the community spread of COVID-19. It's not something you may have heard an awful lot about in the mainstream media, certainly for the scientists and the healthcare and then certainly the environmental health professionals that are with us, both in academic and in practice in the governments across the state. You will have heard of this. It might not be that much of a news to you, but with other disease and viruses that we have tracked using this type of examination. But for COVID, it is relatively new. And so this session is going to talk about a series of setbacks in COVID testing has made it difficult to keep up with the spread. We've heard about the governor say from the very beginning that we have been behind this virus every step of the way. So today's presentation really tries to position our communities to help the state, position our counties to get ahead of this virus on round two. Obviously, round one has come. We're into round 1.5. The subsequent rounds that come about from this depends on human behavior above ground. But as we look to see what happens in the fall and through the winter months when the seasonal flu activity returns, as will this virus potentially return, this type of surveillance testing can really position the public health experts to understand baseline criteria of the prevalence of COVID-19 through the RNA that is discovered in wastewater. And so we're very pleased to bring this to you to help researchers and public health officials, environmental health directors, county officials begin to look to wastewater to measure how prevalent the virus is or was in our community. The SARS-2 early warning wastewater surveillance platform is a collaboration between scientists from Syracuse University, the SUNY Environmental School, Forestry, and SUNY Upstate Medical. The platform uses the level of SARS-CoV-2 RNA found in wastewater to estimate transmission trends in real time, providing feedback on social distancing and other interventions, help predict hospitalizations from COVID, and give some confidence, additional data set in the absence of transmission from areas with 0 cases. The webinar will present lab methods, trends from the first couple of weeks of the platform operations with plans for continuation. And what NISAC is trying to do today is to try to scale this up and have it be implemented in New York City, on Long Island, in the lower Hudson Valley, and in rest of state for future modeling of the pandemic. Today, we have two professors with us here. Dr. Larson holds a PhD and a Master of Public Health from Tulane School of Public Health and Tropical Medicine. He's an environmental epidemiologist with expertise in large data analysis, multi-level modeling, spatial statistics, geographical information systems, and study design. His content expertise lies broadly in global health, with a specific expertise in mosquito-borne illnesses, global health, and sanitation. We also have with us Dr. Hyatt Green, who's also an assistant professor at SUNY College of Environmental Science and Forestry. Dr. Green holds a PhD in microbiology from Oregon State University, a Bachelor in Science and Education Biology from the University of Georgia. His research interests include molecular microbiology, ecology, water quality, microbial source tracking, and molecular energy. We're very pleased to have both professors with us here today. We do have some real data to present to you today, so a very timely presentation here. Before we get underway, again, I'm very pleased to have a three-part series this week. This is the first of three. The second of three will deal with diagnostic testing and antibody testing, and also the third series will be on contact tracing. Discuss what have we been doing with contact tracing, and what are we likely to be going, where are we likely to be going in contact tracing. But again, that's above ground, and that is dealing with either folks that have been infected and isolating and quarantining, and tracing individuals to discover and try to isolate and quarantine. But what we're talking about here is trying to go underground here and to map out an entire city, or to identify neighborhoods within a town or within a zip code, using manholes and downstream work, working your way upstream. We can begin to pinpoint where we find RNA and try to trace it, sort of the fingerprints of the virus, telling us an antibody of what percentage was infected. But we're hoping that if there's enough interest from the folks that are on the line here, and we have pretty much the whole state of New York on the line at the county level, New York City, Long Island. We do have most of you public health, environmental health, wastewater treatment individuals, that if there is enough interest and we generate enough interest, we could begin to scale this up and reduce the costs for all of us. The hope here is to do sampling weekly, to do a year's worth of sampling and analysis, and then begin to have baselines again set up for when we swing into the second phase of this in the fall. So with that said, I'm going to turn it over to Dr. David Larson. Thank you, David.
Thank you so much, Steve, for that kind introduction. And thank you to hosting us and for all the participants. I'm very excited to be here today. Next slide, please, Jeanette. So we're going to present to you the SARS-2 Early Warning Wastewater Surveillance Platform. And so this is a collaboration between numerous scientists from various expertise. You know, we have Mary Collins, who does spatial modeling and spatial statistics. Hyatt's our lead microbiologist, that he's used to pulling RNA out of the mud. And so pulling RNA out of wastewater is a little bit simpler than that. Brittany Kamush is an epidemiologist specializing in infectious disease. Myself, I've spent 15 years hunting and trying to eliminate malaria in Zambia, building surveillance systems with poor data, trying to understand and empower local governmental units over there, its districts rather than counties, to respond to the transmission in their own areas. We have Leah McKnight from Information Systems, who can help package all this in a secure and confidential transmission to build dashboards and to get data into the command centers. Frank Middleton's at the SUNY Upstate. He's a microbiologist, and he's leading the actual diagnosis of the SARS-CoV-2 RNA, and it's a similar diagnostic that's used basically the same for a person, except we're just using it for a population.
Hey, David, before you go ahead. I'll just have something to say after you introduce Tom.
And then Tong Zhang's a chemist who works with wastewater, and so one of the things we can pull out of the wastewater is the profile of risk of the community that we're serving, and so it helps with the modeling of the hospitalizations that we'll talk about here. Sorry.
So I just wanted to, before we go to the next slide, if you have questions to our attendees, there's a question function on your screen. Please type in that question, and at the end of this presentation, probably go about a half hour, 40 minutes, we're going to take some of your questions, talk about the cost of this, but please send in your questions. And I did want to thank the New York State Association of County Health Officials and the Conference of Environmental Health Directors as well for helping to spread the word about this, as well as the New York State Association for Solid Waste Management. Dr. Larson.
Thank you, Steve. And so we all know about the current challenges with identifying where transmission of coronavirus is occurring and where it is not. And we've been plagued by limited diagnostic availability. And some of those pain points are going to be decreasing over the next few months as new rapid tests come online and our scientific engine in the country starts to generate new ways to detect the virus in humans. At that point, we may start seeing some behavioral resistance in the population where people are reluctant to go get tested. And so this test, the number of cases tested and the positives represent one indicator of transmission, but it's not a complete picture. It's problems with the diagnostic capacity, but then there's also characteristics of coronavirus that make this picture incomplete. And so we know that we have asymptomatic transmission and definitely pre-symptomatic transmission. So any increase in the cases we observe is just what we can see, and that there's some invisible transmission ongoing. There's also a delay between transmission events and when the cases get identified at the testing sites. So we estimate that's maybe about 7 days for those that are symptomatic, but then for those that are asymptomatic, that's indefinite. For the hospitalizations and deaths, those can lag 2 to 3, maybe even 6 weeks after a transmission event. And so we're acting in this state. We're trying to respond in this state of incomplete information and then oftentimes late information. Next slide, please. And so we started the SARS-2 early warning wastewater surveillance program really with 4 goals. The first is to estimate SARS-CoV-2 transmission trends in real time. And so to get rid of that lag, so to observe when do we start seeing the RNA in the population and what's happening in real time. We want to provide instantaneous feedback on social distancing and the reopening phases. And we could use what we see in the transmission in the communities as a lever almost to increase social distancing or to pull back on social distancing. And the better trend data we have on the surveillance side, the more informed our interventions can be. And they can also be geographically targeted. We want to predict hospitalizations from COVID-19. And so that's I won't present data on that yet because we don't have enough data to start this modeling, but that's something for the next few months that we'll start looking at. And then something that is not always thought about, but my career has always been malaria elimination, is how do we actually document zero transmission? So how do we document that a community is free and safe from coronavirus? And so we know that if there's an absence of cases from the health system, that may not mean that there's an absence of transmission. And so here, if we have an absence of cases plus an absence of the RNA in the health system or in the sewer system, the absence of RNA in the sewer system gives confidence to the absence of cases in the health system. Next slide, please. And so our project is based on sample wastewater from treatment centers or pump stations. And then Steve mentioned you can also go to manholes, and we can talk about that in a different capacity. We're going to talk a little bit more about the treatment centers and pump stations. And so the data is collected there. We bring it back to the lab, or the samples are collected there. It's about 250 milliliters is what we pull. We identify within the wastewater SARS-CoV-2 RNA. These are fingerprints of the virus. We try to quantify the viral load in that sample, and we pull out some other metrics that are useful for estimating the transmission trends. And then we start the modeling where we classify transmission. Within those sewer catchment areas, we identify areas where transmission is present or absent, right? And then also where it's increasing or decreasing. And we get the early signs of increase or decrease. And then we can aggregate and relay that information up to the command centers, to the counties, to the state to respond accordingly. All this with the idea that we can allocate our limited resources, save us some money, and get us back to normal. Next slide, please. And so environmental surveillance is a tried and trusted technology, and it was first developed more than 20 years ago. And so poliovirus, if you're familiar with that, it only causes paralysis in maybe 1 in 200 cases. So you can have these silent outbreaks where people have polio, where polio transmission is occurring, but the health system never notices the polio transmission is there. And so with environmental surveillance, you can find the virus in the wastewater and then document that there is transmission, even if you can't find the cases in the health system. And it's a bit simple process where you pull a sample from the sewer lines, you filter that sample down, you bring it back to the laboratory, and then you look for the viral RNA or the DNA. And then this polioeradication.org has some excellent information on the history of environmental surveillance. Next slide, please. So since we're now in the coronavirus pandemic, there's a lot of interest in the wastewater surveillance for coronavirus. There's a Dutch group in early March that they showed the first proof of concept that you could pull coronavirus RNA out of the wastewater, and that would actually precede the information from the health system, the number of cases in the health system, by a number of weeks. And other groups are doing this as well. You have Massachusetts and Montana, Arizona, all documenting this, Australia and Paris. And so it is a very robust technology. One thing to note is that every group, well, yeah, all right, next slide, please. We can go over that in a little bit. And so the method that we use, we work with the county sanitation engineers, and they pull a sample for us. With Onondaga County, they're doing 24-hour composites. With Cayuga County, they're doing morning and evening grab samples. And so they bring those samples into the lab. We load those into centrifuge tubes, and then we spin them in an equipment called an ultracentrifuge, which spins at 150,000 times gravity, about 45 minutes. That then concentrates the DNA and the RNA into a pellet at the bottom. And then we look for the primers, the genetic sequence that's unique to SARS-CoV-2, the novel coronavirus, using nucleic acid extraction. Next slide, please. All that total workflow is about 5.5 hours. Now, at the same time, we're looking for a few other markers in the wastewater that will help us to help us standardize the numbers of coronavirus to the population. And one of those is crass phage. That's a bacterial phage that occurs in your gut, and most everybody in the world has it. And so we can standardize our coronavirus RNA to the DNA of the crass phage and get a measure of population density there. And then this takes 5.5 hours, and we have results ready definitely the next morning, and maybe even the same day, depending on when the sample arrives. Next slide, please. And so when we're detecting the SARS-CoV-2 RNA, we use 3 separate diagnostic tests. So take through the slide. This center picture here is a pre-centrifugation test tube, where you have the wastewater on top, and then this clear liquid at the bottom is a sucrose cushion. And that acts as a filter for the wastewater, such that the only thing that passes through that heavy syrup is RNA and DNA. So the picture on the right shows that pellet, which is basically all the RNA and the DNA from that wastewater sample. It's all collected there. From that pellet, we then test 3 separate times, and we get a positive or absence in each of those 3. And that's useful for low transmission communities and providing confidence around communities being free from transmission. And then for those communities where we get 3 positive hits, we also quantify. We take the mean number of RNA copies, and that's basically a count of how many different virus fingerprints we find in that sample. And that's useful for understanding the transmission increases and decreases, and it's sensitive to the rise and fall. Next slide, please. And so this is the city of Syracuse. There should be some, sorry it didn't show up, but there's some catchment areas here, and there's basically 10 or 11 separate catchment areas. Downtown Syracuse, I've circled here, and I think the next slide should be a little bit nicer to show where we're operating. If you could go to that one, please, Jeanette. And so here on the left is our map from May 7th, and you can see the different catchment areas delineated from the wastewater. And so the first test that we run is that number of positive hits. How many times out of those 3 tests for each sample did we identify SARS-CoV-2 RNA? And the dark red here is where we found it 3 times, and we found 3 out of the 10 found 3 hits. Then a week later, we had 8 out of the 10 with 3 hits. And you can see on the right side this increase in the number of positives, right? Next slide, please. And then from those tests that we're able to get 3 positives out of, we can quantify the number of RNA copies of coronavirus that we find in the wastewater. And so here, the more copies of RNA coronavirus would signal that there's more transmission in that community. And so May 7th, we observed, Wetzel Road catchment area, a pretty high transmission. Lake Creek and the Metro Main also with a little bit lower transmission than the Wetzel Road. May 13th, looks like almost every single catchment area increased in transmission. Every single catchment area increased in the amount of RNA that we found in the wastewater, which may signify an increase in transmission, except for Wetzel Road, decreased quite a bit. And Wetzel Road is one of the places where we've had outbreaks in the senior living centers. Next slide, please. Now, well, this didn't show it, but if you show the bottom right, that's the cases, the cumulative cases within zip codes as measured by Upstate Hospital. And so Upstate Hospital, they have about 40% of the county cases, and you see that we have the most cases coming from that downtown Syracuse area, similar to where most of the RNA was found, as well as Wetzel Road. And so we're starting to see a correlation between what we observe in the incidence of the case with what we find in the wastewater. All right, next slide, please. So our group's next steps. So right now we're expanding. We're currently in 11 catchment areas in Onondaga County, and the county's agreed to give us 4 more catchment areas. So we'll have 15 different catchment areas in the county. And then today, the first samples arrived from Cayuga County, and we're open to working with more counties. We're seeking funding from multiple different sources, and we also have some ideas for you to help us to try to get some of that funding and bring this to you. We have a price model ready for scale at about $200 per sample, and for 6 months worth of samples in Onondaga County, that's less than $50,000. And this is a bare bones price. There's no profit markup on this. On the modeling side, we're ready to provide the first evidence of how the reopening Central New York is affecting coronavirus transmission. We'll wait till Friday's analysis and then the week after to observe that. But that will be weeks before that increase in transmission actually shows up in the health system. That's one of the big values here is the early understanding of what is happening with transmission in the communities. But then we also need more data before we're able to start modeling hospitals and really understand that relationship between the number of RNA copies and the transmission level. Right now we can observe fluctuations, increases, decreases, but we just need a little bit more time to let that play out. All right, next slide, please. And so how can this platform help your county? You know, this figure on the right, this is part of the dashboard we're building for Onondaga County. You'll notice that it has 2 data points right now. Next week, we'll have a 3rd data point, and the week after, a 4th. And we'll keep this going such that we'll have a trend line of transmission in the community. And that trend line will show whether it's increasing, decreasing, relatively the same. In about 3 to 4 weeks' time, we'll be able to provide modeled estimates of hospitalizations back to Onondaga County. So what are hospitalizations going to look like in 2 weeks, given the transmission level in the county? And when you think about modeling coronavirus, there's 2 different types of models. 2 general types of models. One's a simulation model. Those are the early models where it's a simulated population going through. And the other is more of an observed model, where you look at what's happening, how the wastewater, and the way that we would look at it is how the wastewater levels then correlate with the hospitalizations 2 weeks later, and then build the model that way. And it's a more accurate way to predict hospitalization numbers. So you'll be able to estimate the coronavirus transmission in real time, the trends, what's happening. It'll provide instant feedback on social distancing and reopening phases. And again, think of that lever in terms of we need to do social distancing. And we're not talking like social distancing everywhere for 3 months or 2 months, I think, now that we've done it here in New York. This is your neighborhood has a spike in coronavirus, so let's do social distancing for a week and decrease this, allow the contact tracing to catch up and clear out those chains of transmission. That's the type of precision of the interventions that we can use instead of this broad scale shut everything down, that paradigm that we've been in now. We also be able to predict hospitalizations from COVID-19 over time. That'll be forthcoming with more data. And then importantly is that giving that confidence of absence of transmission for areas with 0 cases. All right, next slide, please. So if this is of interest to you, and I realize that I told Steve this is going to be 15 minutes, and I pretty much stuck to it, but I'm nervous, so I'm talking fast, so sorry about that. So if you'd like to scale wastewater surveillance, we'd love to work with you. Prithvi Kalaru, he's helping to manage the relationships with the different counties, and so you can email him. My email's at the end of this as well if you want to talk directly to me. And so we can do that, and we can put together a sampling plan, and we can put together a memorandum of understanding and look at our funding to do so. So that's one way. The other way is to request the statewide scale up of this, and that's from the governor's office, from Congress, and the Senate. And we've estimated that $4 to $5 million would get us through the end of the year, scaled up surveillance on at least a weekly level, maybe even bi-weekly, with customized sampling plans for each county, and that we could do this really relatively inexpensively. You know, when we talk about having these dashboards and really informing the social distancing, really informing the hospitalizations, and informing the next wave, you know, that's a high value for a relatively low cost. Next slide, please. So, I apologize, I'm nervous, and so I'm talking quick, but thank you very much for listening, and we can talk through the science or the projections or anything of interest. And my email's here at the bottom if you have questions. And again, it's a really great team we're working with, and definitely a team effort. So thank you.
So thank you, Dr. Larson. Just want to remind our viewers that this was put together on short notice because we wanted to include this webinar as part of our series of 3 webinars on combating the COVID-19 pandemic. And so we are archiving this, and this will be available so that you can share it with other individuals within your department or within your city or within your county, and we'll make sure to get that around. So a couple questions we'll go over here now in the time that we have here. The first one here, David, is can the measurement be done in a smaller area within a sewer shed?
Yeah, it's a great question. And so it can be done within smaller areas. So we have advised Syracuse University to institute weekly wastewater sampling coming out of dorms. And so we're working on that plan to pull the wastewater stream from dormitories, because they have a motivation to open in the fall with in-residence education. And so you can look at dormitories, and you can look at factories, and you can look at even hotels, and at the small level, the small building level. Now the catchment area basically is that population you're trying to get, and so you can get smaller catchment areas depending on the capacity to pull a sample, either through a manhole or through a pump station, and then that sample would be representative of the population and the transmission within that community. And so definitely a good question.
Okay, David, next question here is is there any way to separate out waste discharge from a hospital facility within a particular neighborhood? Do you factor in such things where there is a known COVID-19 infection rate within that facility?
Yeah, and that's one of the things that's a little bit of a challenge and an opportunity. And so we're thinking about pulling the wastewater from that discharge, because we know the number of COVID-19 infections in that population, and then we can estimate a little bit about what the limits of detection are and how it translates to the population prevalence and things. So on the science side, it's an opportunity. On the operations side, it's a little bit of a challenge. And so we'll have to account for that on the modeling. And so building this database over time, we'll be able to understand that we have, you know, hospitals in these catchment areas with this number of COVID-19 patients at the time of our sampling date, and then we can adjust our estimates of the community transmission from that. So it's a little bit of a back-end approach to sort out the hospitalization problem.
Okay, next question is, why did you choose ultracentrifugation instead of other virus concentration methods? Did you evaluate virus recovery?
Very good question, and Hyatt, why don't you take this one?
Sure. Yeah, that is a great question. We did evaluate some other methods. So we evaluated tangential flow, filtration. We evaluated the use of centrifuge filters that you might know by the name Amicon or Centricon, and we evaluated PEG precipitation. And in some cases, we also ran trials combining a lot of these different methods. And there's various reasons why we went with ultra centrifugation. So the first is that we have an ultra centrifuge, all right? So we utilize that, and that enabled us to make the rest of the process cheaper and faster. So the other reagents that we use in the process are fairly cheap. The exceptions might be the DNA, or excuse me, the nucleic acids purification kit, and the qPCR reagents that we're using. But the rest of the process is salt water and sugar water, right? So fairly cheap. Recovery is something that we're looking at right now. Actually, we've got data right now that's running that should give us a good idea of recovery. We do know that with the other methods that we tried, we were getting non-detects run on the same sample. But with this method, we're getting detects. So we don't have a precise number for recovery yet, but we do know it's better than the other methods or combinations of other methods that we tried.
And then two other points on that. Using a Centricon or an Amicon filter would run into supply chain problems, distribution problems. So it'd be very difficult to scale. And so we can scale this method without any supply chain challenges. And then the second on that is that we're getting very good results at a prevalence of infection in this area of 1 to 2%. You know, the percentage of the population in Onondaga County with an infection at any given time is likely less than 1%. And so we're quite happy with the results we have and the methods and fortunate that the method we've settled on is a high quality one, probably the best method.
Okay, and we're talking about a population here, just for our listeners here, of about 500,000, just under 500,000 population in Onondaga County. Dr. Larson, what is the analysis holding time for the sample, or to Dr. Green, what is the analysis holding time for the sample? Any special preservation requirements?
So I can answer that. We would like to get to the sample within 24 hours of when it's collected. The sample would undergo some changes. This is RNA that we're trying to detect, and so there is some rate of RNA degradation over time. That you probably want to keep the samples, we keep them temporarily at 4 degrees, keeping them on ice during transport. Not dry ice, just wet ice is recommended.
Okay, again, what we're trying to discover here, or use this technology, the Association of Counties is bringing this webinar to you, hoping that we might be able to use this additional environmental health, public health surveillance, so that counties, the city of New York, regions of the state can have a detection or surveillance information provided to government officials before actual infections in humans can be detected. So having this information can help with contact tracing or isolation and quarantine before actual infections are being spread. Next question I wanted to put before you, gentlemen. How do uncertainties regarding the virus shedding rates over the course of the infection factor into the ability to be quantitative?
Yeah, that's an excellent question. And so we have, you know, the RNA is shed maybe up to 28 days from infection to recovery. In feces is from one report, and other reports will start coming out. They show variation in that. And so on the modeling side, we'll try to model the number of RNA shredders shedders in a community. So the number of people who are not only infectious but are then also just shedding the RNA after their infection is cleared. And so that's something that needs to be worked out with the modeling. Now we expect that variation to be relatively constant at a population level across time. And so even though the translating the number of viral copies we find in the catchment area to the exact prevalence of the number of the cases of coronavirus or the infections of coronavirus, we can still observe that relationship's going to be difficult, and it's going to be a lot of science to figure that out. But we expect that relationship to be relatively constant over time, and we can still observe changes, increases and decreases in the RNA that's found in the wastewater to look at to act as an early warning platform. We do that anyway with the health system metrics we have now. So right now, the health system metric of confirmed cases, there's a relationship between the number of confirmed cases at the testing sites to the prevalence of cases or the prevalence of infection in the community. And that's, those confirmed cases are not catching every single infection. They're catching just, maybe half, maybe a third of the infections, but we can still watch the number of cases go up and down as an indicator of transmission. And so that principle, we're applying it to the wastewater, where over the next year, we'll really work out the science of translating what we find in the wastewater to the community numbers. But in the meantime, we can still use this as an indicator and an early warning indicator of increases and decreases.
And David, if I could add on just a bit to that, that's a great question, and that certainly does complicate, what we're trying to do. And Dave mentioned that the virus can be shed 28 days after the onset of symptoms. The other thing, though, to keep in mind is that a few days after the onset and symptoms, those that do shed the virus are shedding so at a very high rate, at around 10 to the 6th or 10 to the 7th per gram of feces, right? And when you get later on, day 14, day 21 after the onset of symptoms, the concentration of shed virus really goes down to like 10 to the 2, 10 to the 3, or even to undetectable levels. So there is, I think we can take advantage of that previous data of how shedding rates change and use that in our calculations of predicting the number of infected individuals on the ground.
Might be a little preliminary here, but any preliminary information, what concerns you the most from transmission and spread at this standpoint?
Well, if you go back to the graph of the quantified RNA over time, the 2 time points, it's 2 time points, so it's very early, but I would have preferred to see that go down across the board or stay even as opposed to go up. And so, we'll see what happens with this next week, but we want all the numbers to go down.
Okay. Thoughts about the accuracy or the applicability in rural New York with a higher proportion of individual septic systems. Obviously, not as helpful when you're in rural areas with more individual septic as opposed to municipal or private.
Yeah, it's definitely true. And so the septic systems won't contribute to this surveillance network. And so it would be something that with rural counties, we'd figure out the sampling plan of where it makes sense to sample within the larger towns and villages and cities. And so there is that caveat. Now we expect a little bit of slower spread in more spread areas. And so this would allow us to, and so so we're aware of that, and it's I'm kind of hemming and hawing here.
Okay. So the next comment here is more of a comment than a question. A representative sampling is key. It's important to get a flow-weighted composite sample rather than a grab sample in a study such as this. So it's sort of a recommendation from someone It's especially as important as you go upstream in a catchment system.
Yeah, I definitely agree. Definitely agree that we want a representative sample, and that's what we've got with Onondaga thus far. And it's the sampling paradigm is going to be influenced by the capacity of the county. And so in conversations with Cayuga County, the city of Auburn, their ability to do that 24-hour composite was a little bit less than Onondaga. And so we're going to test out the grab samples, and it's not a 24-hour composite, but we're going to use a morning and evening composite. And so we'll be able to give more confidence on how that relates over time.
Your confidence level with the team on the extraction and quantification method, trends you're seeing on positive and negative controls and other quality controls.
Yeah, that's a great question. We are seeing great results in terms of controls. So the different controls that we have are processing control. This is just where instead of wastewater, we use distilled water to load into the ultracentrifuge. In addition to that, with every batch of nucleic acid extractions, we run extraction blanks, doing the same thing, using distilled water instead of a dissolved pellet. We also have at least 3 no template controls on every qPCR plate, and we wouldn't believe our results at all unless every one of those came out negative. So that's a great question, and that's something that we take very seriously in the lab. We run our qPCR test with a unidirectional workflow with separation of space. So we have different preparation areas for different phases of the process. My technicians can only work through the process in one direction so that they're not carrying back contaminants to the reagent prep room unless they go home, take a shower, and change clothes, and then they can come back. But we try to set up the workflow in a way that limits the backflow of qPCR amplicons, and we have very good success with that so far.
The next question is, if we have an ultracentrifuge, a piece of equipment in our county or jurisdiction, is there ways that we could work together with having this technology in our particular region and plug in with your efforts?
Yeah, definitely. We don't anticipate running an entire every single sample in Hyatt's lab. It's actually Frank Middleton's lab.
Okay,
and
terrific.
So definitely would want to collaborate on this, and so please reach out, email me, and I'll organize the conversation with Hyatt and figure out how to put all the data together.
How important do you think it is to normalize estimates by population? This has been a sticking point in other applications of wastewater-based epidemiology. Is enough known about crassphage excretion to use it as a population normalizer?
Yes. Yes, crassphage was originally designed as a microbial source tracking marker. So a lot of work has gone into establishing the methods of crassphage detection as both specific and sensitive to human fecal contamination. There is, however, less information. We do have some information on the shedding rates of crassphage. We are working right now on previous estimates of about 10 to the 7th crassphage genomes excreted per gram. Ideally, in every area that we test, we would go and test fecal samples, and that's something that we may do in the future to get kind of a better gauge of what area-specific shedding rates are. But the idea is that it's a very cosmopolitan, very common organism, and since we're testing wastewater, which is a kind of an average or a composite, we feel that those numbers probably wouldn't fluctuate greatly among the population or over time.
When you're talking about shedding of the virus, Dr. Green, do you mean shedding of the viral RNA or shedding of the infective virus?
Yeah, that's a good question. it's mostly going to be viral RNA. There is only, as far as I know, things are moving fast, but as far as I know, there's only been one fairly controversial study that claimed to find infectious viral particles from feces. Other groups that have tried to reproduce that have not been able to. So it's unlikely that infectious active viral particles are making it into the wastewater.
Do you expect that the COVID-19 virus could linger for some time and give what could amount to false positives? Is there anything known about the dynamics of SARS-CoV-19 or any virus in sewer systems?
Yeah,
that's a fear. And the fear is that we would be less sensitive to decreasing transmission than to increasing transmission. And that's something that over time, as we have more data, we should be able to see. And so we want to see the wastewater data it used in conjunction with the cases. And then we need some more science around just that precise question of the long end of the tail of declining transmission.
To your knowledge, is the federal government, are there any other states undertaking similar early warning systems?
I wish the CDC would have put this in place in March. You know, it's such a when the Dutch group showed that it was possible, it's such an old technology that it makes so much sense to just have this scaled up nationally. We're not aware of surveillance platforms. You know, there's a company out of Massachusetts called BioBot that is trying to figure out what they're doing, but they have a hodgepodge of metropolitan areas that they're pulling samples from. But to be useful as a surveillance platform, you know, it has to be in conjunction with the county health department, the county executives, the state health department, and into a centralized and public-facing database. The real value from a coronavirus control standpoint, one of the real values from a coronavirus control standpoint is the ability to communicate back to the community, maybe even at a neighborhood level, that you've had an increase in a coronavirus in the sewer. Let's do as much social distancing as you can over the next week so those contact tracers can snuff out those chains of transmission. But we're trying to, you know, get this going quickly. So I think we're some of the first groups that are involved with this.
Okay, the last question we'll put out there is, any thoughts on how this testing can be scaled to regions with septic systems or cesspools?
The question is whether those septics or cesspools are community-based or individual houses. And so it doesn't make sense to scale this to an individual house septic level. At that point, it would make more sense to do a personal sample of the house. But it does definitely, or a pooled sample of the house. But it does make sense to scale it if it's a community cesspool or community septic. And then it's working with the sanitation engineers. And sanitation engineers, at least in Onondaga County, and I'm guessing across the state, are really quite good scientists and fantastic with what they do. And so we defer to them and their sampling procedures for those types of areas. But it should be possible, yes. In places where I work normally in Kenya and Zambia, they have open sewers, you know, and big cesspools, and they'll pull samples from those.
Okay.
To monitor poliovirus, and now coronavirus, they're starting to.
Let me thank David Larson, PhD, MPH, Hyatt Green, PhD, both at Syracuse University and SUNY College of Environmental Science and Forestry at Syracuse University, and Upstate Medical for their information here that they've shared with us here. Want to just remind folks that if you have an interest in this, please email us at coronavirus@nisac.org So coronavirus, all one word, at nysac.org. And we'll include you and connect you to the speakers here. Last breaking question here for you gentlemen, wondering if this testing might be valuable for testing at larger wineries or venues with septic systems.
Yeah, if you can access, yeah, it makes sense. If you can access that septic to pull a sample from, then you'd definitely be able to see the coronavirus spike. And for tourism, you know, how much value would a hotel or a winery have to have a documented trend of no coronavirus RNA in the wastewater? It'd be useful for sure.
Well, it applies to in a single vineyard or a winery. They might see 2,000 tasters in a single day. That would come in. This would, of course, apply to other industries as well, but clusters like that, great suggestion that came in there. Also, someone is suggesting to encourage the archiving of samples for future analysis and backward studies should the need arise.
Yeah, we got them in the deep freezer hide, I believe.
Yep, we're doing that. Yep, not a huge volume, but we're saving about 40 mils.
Okay, this has been Slowing the Spread of COVID-19, part 1 of 3, examining wastewater to detect community spread of COVID-19. Our panelists were David Larson and Hyatt Green. Very appreciative of your time today, gentlemen. Folks that are interested, please contact us at coronavirus@nysac.org, and we'll make some connections, hopefully with some aggregation of this. We can get the cost of this for our communities down into a scalable way that we could procure and start implementing this and start getting a year's worth of samples. Thank you very much, gentlemen, for joining us today.
Thank you.
Thank you very much, Steve, for having us.
Thank you.